It evidently is too early in the morning for me to be recording because I just sat here and recorded all of the Med-Surg and I didn't push a red button. So I must be sleepier than I think I am. But that little red button's awful small to be looking at it 6:30, 7 o'clock in the morning after getting up at 4. So anyway, we're going to do this one again. We're going to do the Med-Surg all over again. Now you'll notice that my PowerPoints are very abbreviated from what the chapter. I've left some things out. There's just too much information in the chapters for me to go over everything. So I'm hitting the high points and the areas that I think are important for you to know. Okay? I just don't know how I managed to keep doing that. Number 2. This one may even be quicker than the other one was. So basically what happens with the difference between medical surgical problems and cardiac problems from someone who isn't pregnant is that you have the baby on board. And having the baby on board changes a lot of the dynamics of the vascular system that you have to take into consideration during your care of these patients, along with the care of the fetus and monitoring the fetus. Cardiovascular changes. Remember we talked about the changes that occur in normal labor and delivery as the patient gets further along in pregnancy. Vascularity increases at about 50% of the volume. The systemic resistance is going to decrease so that we can have good blood supply to the placenta. We have quite a bit of cardiac output during labor and delivery. And then we have the intravascular volume changes that we see after birth. And we're going to go through every one of those. Cardiac failure can occur at any time during the pregnancy, labor, or postpartum, especially those that have cardiac issues. So cardiac decompensation is the inability of the heart to maintain a sufficient cardiac output. And Ms. Lindsay will be going over that more in depth with the adult. And I will be going over it with pediatric, but right now we're talking about pregnant women. Cardiac decompensation can develop anytime there is myocardial disease, valvular disease, or congenital defects, such as mitral valve prolapse. You can have ventricle septal defect. You can have atrial septal defect. So you can have all these things going on that can happen and to cause cardiac decompensation. And once you have decompensation going on, you've got a major emergency occurring. So the very first sign of having decompensation is going to be fatigue. And then with a lot of the with most pregnancies, patients become fatigued whether they have cardiac problems or not. But if it's someone with a cardiac disorder, sign of fatigue is your very first one, and you have to be sure and tell them. You will start having fatigue when you're just trying to get up, go to the bathroom, take a shower, and get ready for work. And most people don't get tired when they do that. They get tired when they do all that, go to work, and after a couple hours into their shift, they're really tired. But with cardiac patients, you got to be very careful about that. The signs and symptoms are listed in a box on page 714 in your book. Tells you what the woman will have subjective symptoms and then what you will look at as objective signs. Of course, the first thing is going to be fatigue, difficulty breathing, heart may be having some palpation or may see some edema because of the pulmonary things going on. Then you will notice crackles at the base of the lungs. Rapid respirations are a big thing, and a rapid pulse, and so forth. So we have 4 classifications of cardiac disorder, and that is according to your New York Heart Association. They have, that's widely accepted, so this is what we're going by. 1, 2, 3, and 4. 1 is asymptomatic at normal activity. That's a good one. That means that we don't have very much heart damage going on. Class 2 is when it's symptomatic with increased activity. So if, they went out and decided to walk around the block and they became symptomatic, having respiratory issues, feeling smothered, heart rate way up there. Class 3 is when they're symptomatic with normal activity. They get up, go to the bathroom, take a shower, they become fatigued, out of breath. And then class 4 is when they're sitting on the couch watching TV and they're out of breath and fatigued and have a heart rate that's high. So pregnant women can progress through all 4 of these during a pregnancy. They may be in a class 1 before they got pregnant, and then as the pregnancy develops and all that vascular change occurs, the pressure changes in the abdomen, it can go far and develop all the way into class 4. So that's why we need to have a good control on these patients at the very beginning. So again, know those signs and symptoms that are on page 7. I forgot already, 741. Was that what I said? 714. I'm dyslexic this morning as well. We do not advise breastfeeding because it takes so much effort for the mom to do that, and her cardiac output is going to not be good enough for her to be able to do this. She'll become very fatigued, and it will stress her heart, and she'll go into decompensation. We want to have an EKG at the beginning of the pregnancy, so we'll have baseline. Be sure we teach mom about ultrasounds, NSTs, kick counts. We need to have her be doing these as soon as she's feeling movement. We need to have her doing kick counts. We have to restrict her activities if she goes from a class 1 to a class 2. We need to be sure that we are putting her on semi-bed rest, and she may go to total bed rest before it's over. Infections ought to be treated promptly with antibiotics. Nutritional counseling is very important. If they have been on a specific diet before they became pregnant, we try to keep them on that diet and just increase their calories. Calories should be increased by 400, so you should have an increase of 400 calories. If they were on a 2,000 calorie diet, then you would have a 2,400 calorie diet that they need to increase, so you'll have adequate calories for fetal development. That's not a whole lot of calories. I can eat that in 2 bites. Anticoagulant therapy, usually we use heparin because it does not cross the placenta. So if they have to have anticoagulant therapy, heparin is our drug of choice. Intrapartum care, this is when they're in labor. ABGs are a must. We got to know if they're having any type of metabolic issues. Swan-Ganz should be used with a class 3 and class 4. Most of these patients need to be delivering in a special high-risk ICU OB. They need to be in that particular type of setting. Of course, in our area, you don't usually see that particular type of setting, but they usually go to, even with UAMS does not have that particular type of labor unit. But it would be awesome to have a Swan-Ganz placed. They should be on EKG, have an EKG done. They should be on a heart monitor, actually. So they should be placed on a heart monitor that's doing a continuous EKG for us. Continuous pulse ox and continuous fetal monitoring. Be assessing that respiratory rate for signs of decompensation. You get a pulse over 100 and respiratory rate over 25, decompensation is probably occurring. Should have antibiotics before and after delivery. Usually class 2 and greater get penicillin. Keep that patient in a semi-Fowler's left lateral position. This is the best position for them to get vascular blood flow throughout their body and to keep the baby oxygenated as well. That side lying position is going to promote that hemodynamics that we're looking for. We want to use an epidural for their pain control and for delivery. We want, of course, with epidural, remember we have to watch for hypotension. They develop hypotension, what's going to happen to their cardiac output? It's going to decrease. Don't use that terbutaline. Remember we talked about how it makes you feel really nervous and makes your heart rate go up, so it puts stress on the heart. So you cannot use terbutaline if you are going to try to stop a labor or if you're going to try to stop contractions from occurring. We can use oxytocin with these patients. It doesn't affect their cardiac output, and we prefer for them to have a vaginal birth over cesarean. So during labor, during delivery, we would like to deliver them side lying if possible. Never have their legs put up in stirrups to where the knees are bent and pressures put on the knees, because it will develop DVTs. Always have their feet flat on the bed. Open glottis pushing is less stressful on the heart and should be encouraged in these patients. They should have an oxygen mask because they're using up a lot of oxygen and aren't able to easily replace it. We've already talked about the penicillin. Don't use the ergot products if you happen to have hemorrhage afterwards. Oxytocin is always your first drug of choice. Then the postpartum care. That first 24 to 48 hours is your most difficult time hemodynamically. So they really have to be monitored. You want to keep them on the heart monitor during this time. Our cardiac output goes from being decreased to increasing, and it increases rapidly. So if we're having a rapid increase of cardiac output, is that putting a strain on our heart? Yes, because it didn't happen gradually. So it's like the heart was doing decrease, and then all of a sudden it's supermodel. And so you really have to watch them. That extra fluid that we've had in there has mobilized into the vascular compartment. Our intra-abdominal pressure of the baby and the amniotic fluid have come out, so that pressure is reduced, which in turn puts less pressure on the veins, so that increases our blood flow to the heart. So when the heart sees how much cardiac output that it's doing, the heart is going to slow down because it has so much. It doesn't need to work faster to get all the blood pumping where it needs to go because there's so much more of it. So you may see some reflex bradycardia from this disorder or from in this postpartum period. So we really need to be watching our patients carefully in this postpartum period. CPR, standard CPR with lateral tilt shouldn't do it. Usually if no response within 15 minutes of doing your standard CPR and defibs. You can do open cardiac massage if the baby is viable. If the baby's not viable, they don't recommend doing that. If there hadn't been any change after opening the chest for 15 minutes, immediate cesarean should be done. I've seen a post-mortem cesarean done once, and the baby did not have a good quality of life afterwards. Developed hydrocephalus very badly and didn't have any other functions other than able, just had normal brainstem functions. Some of the medical disorders that I want you to know about: the anemia, HB, your hemoglobin's less than 11, hematocrit less than 33. Remember, we do have the anemia of pregnancy, which is due to the increased vascularity in the blood volume. There's also the iron deficiency anemia. There's the folic acid deficiency anemia. We have sickle cell anemia. So if we have sickle cell anemia, these patients may not be able to deliver enough blood on oxygen to the through the placenta to the baby. So they may need not only just a blood transfusion, but they may need a blood exchange in order if they go into, especially if they go into sickle cell crises. Asthma is something we have to watch for very carefully, and if they're asthmatic, they need to be told that they need to bring their rescue inhaler when they with them at anytime they come into the hospital. We definitely want to monitor that respiratory status, be listening for tightness and wheezing in the and Ronchi in there. Avoid use of any prostaglandins, morphine, meperidine, and NSAIDs. We really are limited on the type of IV fluids or IV narcotics that we're able to give the patient, so they're much better off with an epidural for their labor pains. Then we have skin disorders, we have PUPS, and we have acne. You know about acne. PUPS is puretic urticarial papules and plaques of pregnancy. I've seen this a couple of times. Patient breaks out in a rash. It's extremely itchy. We can't treat the PUPS, but we can treat the symptoms, usually Benadryl, Benadryl cream, and corticosteroids if it's really, really bad. And usually if you have it once, you'll have it again. Acne worsens in that first trimester, is going to improve by the third. Avoid Accutane at all costs. We know that Accutane should never be used in pregnancy because of the fetal anomalies that occur. Then you have your GI disorders, and you went through some of these GI disorders last semester. Your patient just wasn't pregnant. So cholelithiasis develops in pregnant women because they have that slowed down peristalsis in the gut, and therefore things just don't move quickly, and it becomes stasis, comes in a state of stasis, and then the stones will develop. Cholecystitis is what we see more often. So we try to teach them to avoid fatty foods, fried foods. We try our best to get diet to control cholecystitis, but we in the last few years we have been doing surgery. So pre-op and post-op we should be doing fetal heart monitoring, and then after they deliver we should be watching for preterm labor in case the surgery caused some stress on the uterus. Appendicitis, same thing. You have a string pain. They usually do continuous fetal monitoring, is usually ordered, but it's really hard to do continuous fetal monitoring depending on the gestational age. But it should be done if we can possibly at all do it. We're watching for decelerations and uterine contractions. If the fetus isn't viable, we can just Doppler fetal heart tones before and after. We may have to give tocolysis. Be sure that we always have that uterus tilted anytime they come back from surgery. Trauma, 80% of our pregnancies have trauma, usually caused by acts of violence, stab wounds, shootings. If you notice bruising on your patient and you suspect abuse, you have to report it. You should always make sure that your abused patient has a referral number for a safe house. And it's the number one thing that you can do when they come in, because they will not tell you that this is abuse, or they would already have gone, but give them a number for a safe house in case they need it. Fetal survival always depends on maternal survival. So if there's any trauma, abdominal trauma, fetal monitoring is essential. Your fetal heart rate changes. It's kind of like a pulse ox. You can watch your fetal heart rate. Mom may have been in a car accident and she's not doing well, but she's stable, and our fetal heart rate starts showing decelerations and variability starts decreasing. This tells us that there is an impending maternal shock is about to occur. Your baby will tell you about those changes before mom's vital signs will tell you that's going to happen. By the time a pregnant woman's vital signs says, I'm in shock, I'm hypoxic, your baby's going to be very compromised, and it's going to be very hard to bring mom back out of that because it's such a loss before those signs start showing. Treat mom first. Fetus won't survive if mom doesn't. Fetal maternal hemorrhage can happen potentially after trauma, leads to fetal anemia and death. Of course, if mom's Rh negative and there's been some damage and some hemorrhage, say the placenta's been damaged and there's been an exchange of mom and baby blood across the placenta, it can result in hemolytic disease if the mom's Rh negative. A Klein-Hauer-Becke test should be done anytime abdominal trauma has occurred, because if the placenta is located in the anterior part of the uterus, there's chances that you will see an abruption. The Klein-Hauer-Becke test, also known as a fetal hemoglobin test, basically what we're doing is we're drawing mom's blood and seeing how many fetal cells are in her blood. If we find any fetal cells in mom's blood, it usually is indicated of greater than 30 milliliters of blood loss. They can tolerate 2 to 3 cells seen in the blood and need to be monitored carefully to make sure that it may have been just a minor loss. But if you see more than 10 fetal cells, you usually need to go straight to cesarean because there's bleeding occurring. I had one come in that we did a Klein-Hauer-Becke test on, and it took me forever to get the results of the test. Called the lab and I said, "Where's my Klein-Hauer-Becke results?" And she said, "I'm still trying to count them. There's so many of them, I can't get a correct count on them." If she'd have called me and told me that, I wasted an hour waiting on her to do that. And anyway, I called the doctor and we sectioned her and we saved that baby. The baby before that baby came in with abdominal trauma, we didn't do a Klein-Hauer-Becke on her, and we lost her baby. And from that day forward, Klein-Hauer-Becke tests were done on every abdominal trauma that came in. And that is all of that one, and I hope I pushed the red button. Yay!